Good morning, good afternoon, everyone. Thank you very much for joining us today. My name is Leanne Doherty, and I'm the Activity Manager for the French-speaking West Africa portfolio of the USAID-supported Breakthrough Research Project. I'm pleased to share with you today a presentation that I hope will mark the beginning of a really fruitful conversation about the value of measuring social and behavior change. I just want to start off by saying that available evidence shows that social and behavioral change approaches can increase modern contraceptive use by addressing the factors that influence demand. However, social and behavioral change interventions often do not receive as much attention as supply-side interventions. I hope this presentation will help us move forward in thinking about how we use measurement as a tool to strengthen the focus of SBC programs and determine the effectiveness and impact of programs that can ultimately lead to increased investment. I want to start off with an overview of the presentation. First, I'd like to introduce Breakthrough Research for those who may not be familiar with our project. Next, I'll give you an overview of how we have explored the SBC Measurement Landscape. I will then share with you the findings on the types of indicators that we found are commonly used to measure SBC and the potential gaps. I'll make recommendations to countries, donors, and implementing partners on how to strengthen their measurement of SBC. And I will share examples of potential indicators that countries, donors, and implementing partners can adopt to strengthen their SBC measurement. And finally, I will share some next steps. About Breakthrough Research. The Breakthrough Research is USAID's flagship SBC research project. We focus on the generation, packaging, and use of innovative SBC research to inform programs. Breakthrough Research is a 5-year project that ends in July 2022. We work with both USAID Washington and the USAID country offices throughout the world. We also work in close collaboration with our sister project, Breakthrough Action. In the Francophone West Africa region, we are supporting family planning investments in 4 of the Ouagadougou Partnership countries. Breakthrough Research is a consortium of partners that is led by the Population Council and includes Tulane University, Avenir Health, Ideas 42, PRB, and Georgetown's Institute for Reproductive Health. So we have a broad range of research-related activities currently underway in Francophone West Africa. We have conducted a landscaping study on provider behavior change interventions and a literature review focused on mass media approaches aimed at youth. We are also conducting evaluations of 2 mass media campaigns in the region. The first is the Merci Monero campaign, which is a youth-driven social media campaign. We are conducting a qualitative evaluation of this approach and incorporating a social listening methodology to better understand conversations that emerged during the campaign on social media. And I'd like to put a plug in at this time that if you're interested in learning more about this, we'll have another webinar next month that describes our work with social listening. We will also be looking at the cost of this campaign. We are also evaluating the Confiance Totale campaign, which is a radio campaign that promotes spousal communication about family planning and promotes health providers as trusted sources of family planning information services. And finally, we are also working to better understand SBC measurement and to support partners in improving indicators for SBC measurement. So the idea to explore SBC measurement and consider recommendations for improvement stems from a series of research and learning agendas that Breakthrough Research developed early in our project. During this process of interviewing stakeholders and reviewing gaps in the evidence base, we determined that there was a lack of consistency and alignment in indicators used to measure behavioral determinants. This process informed our decision to take a more rigorous look at the landscape of SBC measurement. So as we begin to think about this issue of consistency and alignment of indicators, we should consider how improved measurement will benefit SBC programs. Measurement is a tool to strengthen SBC programmatic focus and is used to determine effectiveness and programmatic impact. Investing in rapid, innovative measurement strategies can enable programs to engage in continuous learning and improvement. It can also be used to generate evidence of effectiveness when trying to mobilize resources for SBC. So once we determined that there were issues with consistency and alignment, we wanted to set out and explore the issues more systematically in order to propose recommendations to strengthen monitoring and evaluation for SBC in a cost-effective way. We implemented an indicator mapping activity and set out to answer two principal questions. First, we wanted to understand the extent to which family planning indicators were collected with regard to programmatic reach, determinants of behavior, service delivery, family planning behaviors, policy, and cost. Next, we wanted to identify gaps and what additional SBC indicators stakeholders can adopt to increase the availability of routine SBC data. We focused on the 4 West Africa Breakthrough Action and Amplify Family Planning countries, which included Burkina Faso, Cote d'Ivoire, Niger, and Togo. We conducted structured key informant interviews with stakeholders in November and December of 2019, where we collected program descriptions, monitoring and evaluation and learning plans, and indicator reference sheets. We then compiled this information into an Excel matrix with information on partners and donors, data collection frequency, geographic level, and we coded this by type and socio-ecological level. Our interest in focusing on the Francophone West Africa region stems from the current family planning status in this region. Niger, for example, has the highest average births per woman in the world at 7.6. Modern contraceptive prevalence averages about 20% across the 4 countries, and there are high rates of adolescent pregnancy. Unmet need is also relatively low when compared to modern contraceptive prevalence, indicating the need for more demand generation activities. So as I mentioned, once we had collected the indicators, we compiled the information into an Excel matrix and coded the indicators by type and socio-ecological level. We define the types of indicators as output, which is defined as the result or a direct product of a program's activities. Reach, which is defined as the number or percentage of beneficiaries exposed to an intervention. Intermediate, which refers to the factors that are considered as contributing to behavioral and health outcomes. And outcome, which refers to the desired behavioral or health effect on the target audience. We also classify the indicators by socio-ecological level. The socio-ecological level is a commonly used framework for SBC that considers the complex interplay between individual, community, health provider, and policy context. We define the socio-ecological level indicators as individual, meaning they are indicators reported at the beneficiary level, community, meaning indicators capturing activities at the community level, such as community engagement or engagement with community leaders, facility or provider, meaning indicators reporting on service delivery providers or family planning distribution points. And finally, national or policy, which refers to indicators related to national level policies and plans and costs. We collected more than 1,500 indicators in these 4 countries related to family planning from 55 different stakeholders or projects currently active. We prepared heat maps based on the indicator matrix by indicator type and socio-ecological level. And we looked at all the family planning indicators, and we looked more specifically at SBC specific indicators, which we define as indicators that measure the processes and approaches implemented to motivate and increase uptake and or maintenance of health service related behaviors among intended audiences. So here you see the heat maps for all 1,500 plus indicators collected. And as you can see, we have constructed a heat map for each country. The rows are broken down by the socio-ecological levels, and the columns are broken down by the type of indicator. And what we discover from these heat maps are that, first, the predominant number of indicators collected in each country were at the output level. This may be because output level indicators such as counts are easier to collect. We also see that there are few measures related to reach or exposure of beneficiaries to interventions. And finally, we note that there are a limited number of policy indicators, particularly at the outcome level, which may reflect measurement challenges. While not coded specifically here, it's also important to note that there were very few indicators that measured costs. Next, we look at the SBC-specific indicators. Again, we see the rows are broken down by the socio-ecological levels, and the columns are broken down by the type of indicator for each country. And what we discover from these heat maps are that there are intermediate level indicators at the individual level. However, a closer examination of these indicators, we found that most focus on awareness, knowledge, and partner communication. There are few intermediate indicators measuring ideational factors such as attitudes, self-efficacy, risk perceptions, or social norms. These findings are interesting because we know that there are nationally representative household surveys that collect family planning indicators at this level, but it seems that there's some gaps here. We also note that there are some indicators relevant to SBC programs, and we find few indicators that are relevant to the provider level. Now we will consider some potential recommendations for countries, donors, and implementing partners. An important finding that emerged from reviewing the indicators is that there was a dearth of consistent measures across partners and countries. We recommend that governments consider adopting standardized SBC measures for cross-country comparability so that we are able to see more clearly the behavioral drivers that require attention in each country. We ask governments to specifically consider SBC indicators that are available in the Breakthrough Action Indicator Bank. The Breakthrough Action Indicator Bank provides a sample of indicators for use in SBC programs. The Indicator Bank builds on well-known indicator sources, such as the Measure Evaluation, Family Planning and Reproductive Health Indicator Database, as well as from PMA 2020's recommended family planning indicators. We also introduced in this presentation 12 priority SBC measures for consideration. We also recommend that ministries invest in collecting routine data and monitoring systems to strengthen SBC data for decision-making across all levels of the health system. During the process of collecting indicators for this mapping activity, we look specifically at the core indicators prioritized and recommended by global and regional family planning partnerships. We found that while the partnerships recommended core indicators, these indicators focused on contraceptive uptake and service delivery, and there were very few indicators that focused on demand and behavior change. We also found that the DHS and PMA surveys provide only minimal SBC-related indicators, and these indicators tend to focus on knowledge and partner communication. We recommend that donors consider investing in project-specific surveys that collect a greater number of SBC-relevant indicators than those currently collected. We also recommend that donors regularly convene and coordinate partners to facilitate the standardization of SBC indicators and data collection methods. For implementing partners, we recommend that programs identify, through a theory of change development process, important behavioral drivers that can be addressed with SBC programs. We propose the need for more consistent measures of program reach and the need for SBC and service delivery partners to work together when reviewing data to identify programmatic needs. We recognize that while service delivery programs may focus on the supply of contraceptives or the technical competence of providers, that this cannot be done at the expense of also not considering provider biases and how these may impact the services provided. More work is needed to identify indicators that capture provider behavior and behavioral determinants. Finally, we found a dearth of cost-related measures. Breakthrough Research has developed SBC costing guidelines, and implementers should consider collecting cost data to help support with advocacy, program prioritization, and agenda setting. Next, I'd like to offer some specific SBC indicators that countries, donors, and programs can consider adopting to improve SBC measurement. The indicators that we have identified are primarily available from the Breakthrough Action SBC Indicator Bank. We selected indicators that correspond to points in the ideational model. Evidence suggests that SBC interventions can directly increase contraceptive uptake as well as increase contraceptive use through pathways that address intermediate indicators, such as attitudes and communication around family planning. The ideational model, originally proposed by Kincaid, describes these pathways. To the left, you see different channels for SBC programming exposure. These include quality improvement for services, mass media, community mobilization, interpersonal counseling, and advocacy. We next see that exposure to SBC programming leads to an intermediate stage. This stage includes skills and knowledge and ideational determinants such as beliefs, attitudes, norms, self-efficacy, and spousal communication, as well as environmental support. The intermediate stage then leads to intention and behavioral adoption. So first we look at measuring exposure to SBC programming. And we focus on measuring SBC programming because this enables us to understand the extent to which beneficiaries are exposed to the approaches. We recommend 3 indicators to measure exposure to SBC programming. First, the number of decision makers reached with advocacy activities. Second, the percentage of intended audience who recall hearing or seeing a specific message or campaign. And third, the number of service providers trained in interpersonal communication for family planning counseling. Next, we consider measurement of SBC intermediate outcomes. And by this, we mean indicators that enable us to understand the factors that are contributing to behavioral outcomes. For SBC Intermediate Indicators, we recommend 5 indicators. First, we look at knowledge and consider the percentage of an intended audience who knows at least 3 modern family planning methods. Second, we consider attitudes, and we propose the percentage of an intended audience with favorable attitudes towards family planning, modern methods. Third, we look at norms. We propose the percentage of an intended audience who believe that most people in their community approve of people like them using family planning. Fourth, we look at perceived behavioral control, and by this we mean measuring the percentage of individuals of reproductive age who are confident in their ability to use family planning. And finally, we consider spousal or partner communication. And for this measure, we propose percentage of the intended audience who talked about family planning with their spouse or partner in the last 12 months. Next, we consider SBC outcomes, and this enables us to determine if the behavior has changed. We propose 3 indicators to measure SBC outcomes and cost. First, we look at intention and propose the percent of non-users who intend to adopt a modern family planning method in the future, or the percentage of modern family planning users who intend to continue using a modern family planning method. We also look at behavior and propose the percentage of women of reproductive age currently using a modern family planning method. And finally, while not included in the SBC Indicator Bank, we think it's important to consider costs, and we propose cost per person reached by SBC message. We hope you found this presentation useful and hope that our proposed recommendations and suggested measures are useful. We're planning several upcoming activities to further this discussion. First, we're planning a series of capacity building activities using online platforms such as webinars and springboard discussions to engage countries, donors, and implementing partners on SBC measurement. We're also planning some in-person skill building exercises, pandemic permitting, with country technical working groups. We will be disseminating indicator reference sheets for the 12 SBC indicators for family planning that we have proposed. And finally, we're working on a similar indicator mapping activity in Burkina Faso and Niger that focuses on health areas beyond family planning, including maternal and child health, nutrition, and water and sanitation, so we can better understand the gaps in SBC measurement in these health areas. Thank you again for joining us today, and I look forward to hearing any comments or questions you may have.
Thank you, Leanne, for the presentation. This is Martha Silva. I am also part of the Breakthrough Research Project. I'm data strategist and innovation team lead, and I'll be reading out some of the questions that are coming in. Please feel free to continue sending us your questions. So we have a few questions already.
Oh, sorry, Martha.
Yes?
Yes, I just wanted to also acknowledge the team. Martha was worked very closely with us on the putting together the indicator mapping report, and also Catherine Spielman and Komlan Eden, and a few consultants in Burkina Faso, Bonaventure Yamiogo, and Shebu Dadi in Niger helped with this work. Sorry, go ahead.
Thank you, Leanne. So a few questions coming in. I think I will begin just talking about the process. It seems that there are a few questions that are related to the process. So understanding a little bit more how we went about doing this indicator mapping. Just to describe a little bit more who we contacted and how we gathered these indicators. Komlan, I'm wondering if you can unmute yourself. Do you want to tackle that question?
Okay, so about the process was as it was described in this this presentation. The process go through 4 steps. First, we identify a number of projects targeting family planning, and we go through all of these partner, all of these program manager, or all of these monitoring and evaluation manager, and we ask them about what kind of indicator they are collecting. So we have interview with them, we gather documents, and then we go through all of these first stakeholder to have more stakeholder because of the snowball method we use, and we, after collecting all of this data indicator, all of this document of monitoring and evaluation, we analyze them, and we, as it was described in this presentation, we go through an Excel file, and we gather all of this indicator to make this categorization by type and by the socio-ecological level. So it very, like, I just want to talk briefly about all of this this process. I don't know if I respond to your question.
Yes, I think so, Komlan. Thank you very much. I think that one of the important things to clarify is that the data, the raw data that we were working with are actually indicators, the indicators in and of themselves. So looking at the definitions and what they were trying to measure rather than the data related to the indicators. I'm not sure if I'm being clear. I think this question relates to that. One person is asking, did data indicate any marked differences or similarities between behaviors of those from urban versus those from rural village locales? And Leanne, I don't know if you want to try to answer that question.
So if since we just collected the indicators, we don't have the actual data. I just want to clarify if the question is asking about differences in the data collected or the types of indicators in urban versus rural.
My interpretation is that they're asking about the data. So just clarifying what exactly we're working with.
So yeah, so our unit of analysis was the indicator. So we are just looking at the indicator, not the actual data that was collected to inform, for the indicator.
Great. There's another question here asking, to what extent does the panel believe that measuring of SBC indicators needs to be accompanied by measurement of structural indicators? It seems that positive shifts in many health areas are in part a product of structural change, and thus that would need to be measured.
Sure. I think we've really started to think about this more, particularly when focused on the provider or facility level, because there's a lot of structural level inputs there that shape a provider's behavior or facility level norms. And so I think that, that the person posing the question is right, that we definitely need to consider that aspect. It's part of, I think, why we look at the socio-ecological level, because it allows us to look at those multiple levels. And that we should, definitely be thinking about how those structural inputs are tied into behavior and attitudes and norms.
I'll also just add that we did, so the exercise did include collecting all indicators related to family planning in the beginning, and then we kind of zoned in or focused in on the SBC related indicators, precisely because of this understanding that that in order to see and to be able to track what is happening in the family planning arena, you really do need the bigger picture of what the supply side versus demand side versus advocacy versus all these other things that are contributing to better access to family planning services. You need to be able to track all of these different things moving together. So even though we wanted to particularly look at SBC related indicators, because we believe that the SBC measurement is not necessarily prioritized, we did also look at all other related indicators. So moving on to the next question. What is the value of standardization in terms of meeting unmet need in a particular community? Would a more context-specific approach result in a higher impact? Since you take into account the cultural norms and values in decision-making, it seems you already have the tools for a context-specific approach.
Sorry, I missed that the first sentence you read, Martha, if you could just repeat that.
What is the value of standardization in terms of meeting unmet need in a particular community? Would a more context-specific approach result in higher impact? Since you take into account the cultural norms and values and decision-making, it seems you already have the tools for a context-specific approach.
Right, so I think there's value in both. There's obviously, when thinking about SBC measures, you want to, I think the way that we would propose going about it is you want to know, just as you would with any good public health program, have your formative research and understand what some of those underlying factors are that are shaping, that are sort of the types of attitudes and norms you may be wanting to measure from a quantitative perspective. And then there's, both the value of being able to have these sort of more general questions about favorable attitudes, and also ones that may be more specific and that you'd want to collect through a more project-specific evaluation, maybe perhaps related to a particular norm or attitude in a particular community level context. I think part of the added value and what's been missing with family planning, if you think about some of the other health areas like HIV/AIDS, sort of early on, questions about people's knowledge or different attitudes they had were collected in the DHS, or same with malaria, but these haven't really sort of evolved in the same way with family planning. And so trying to find some particular measures that can be harmonized across country can really help to understand where we are in addressing those behavioral determinants.
Okay,
So,
next, yeah, go ahead, Komlan.
No, I just want to add that it is important throughout this work we see that there is a lack of communication between programs in a specific country. So the standardization I think it's the first step for a program to work together, because we will have the same indicator to interpret, to analyze, and this is an important thing to do. And I think also in a cost, when we think about the cost, how to reduce costs for our program, it is important that the standardization can lead to program putting the effort of the money together to collect the same kind of data. I think this is, I think it is an important thing to go, and in Africa specifically, where we are having some money issue, it is important that we make some change or innovative change in terms of collecting data in the cheapest way. Thank you.
Thank you, Komlan. Maybe I'll just add that there's always, I think that it's important to take into consideration what the data needs are. So what data needs to be collected for what purpose and at what level. I think that's a very kind of basic premise of M&E. And so there is data that is useful for tracking and for tracking, you know, across institutions within a country, across countries as well, where standardization is very helpful, and making sure that we're all defining, you know, key terms and concepts in a similar way, I think is very helpful. And then there's the type of data that is, you know, very useful for individual programs or individual projects, or that are useful for, you know, some communities and not others. So I think that striking the balance between flexibility, adaptability, but also standardization of certain measures, I think is always the balance to seek. So what measures are useful to track to get a bigger picture, and then what type of data is useful for, you know, for these kind of individual community or project level decision making. So I think that's always something to keep in mind. So next, there is someone who's asking, can you give us a little background about the birth rate and family planning uptake in these 4 countries, I think this person means, over the past 2-3 years, both for the general reproductive population and adolescent population. I don't know if we have that slide, Leanne, with the standard indicators.
We just have the one time point, so I don't have the trend data available, but we can certainly go back and pull that and provide that. And I should note, you know, here we're seeing around 5 as the total fertility rate for Burkina, Cote d'Ivoire, and Togo, but Niger is much higher. But the Niger data is also much older. It's from 2012. So, but I think it's still sort of rests at a high level of fertility, and it's an area that there's a lot of focus. I mean, particularly as you see in this slide, with high levels of adolescent pregnancy, which is tied to early marriage. I think the median age of marriage is 15 in Niger.
Okay, so another question coming up here. Social and behavior change is a very slow process and involves all sections of society, horizontally and vertically. It makes the process very challenging too. What methodology was adopted to overcome social barriers and power structures in the society?
So I actually think that behavior change, it can be difficult to challenge, and then at times things can move rather swiftly, depending on, you know, these sort of various levels of determinants. Sorry, could you repeat that again? The question? I lost my train of thought.
So it says social and behavior change is a very slow process and involves all sections of society, horizontally and vertically. It makes the process very challenging too. What methodology was adopted to overcome social barriers and power structures in society?
I mean, because we applied the socio-ecological level, that that aspect is sort of reflected in the policy and national level indicators that we were looking at. So indicators that are looking more specifically at policies, plans, strategic plans, and that sort of level of engagement, sort of looking at the broader policy at national level as influencers on individual behavior.
Were there any standard indicators found between? Oh, sorry, Komlan, go ahead.
Sorry, I just want to add one word, and I think this question is a very important question, and I think that this presentation of the mapping activity show us some gaps in terms of the type of indicator at the community level. So if we want to track how social norms are impeding are being a barrier to behavior change, we need to have all of these measurements in our program to be able to track and to be able to follow how things are moving, things are changing. And I think that it is important that we show we see the measurement as an important tool to allow our program to be able to learn from the strategy, and also to be able to measure the impact we are making in the community level. So it's important that all programs, we should ensure that we have the good indicator at this level, and it is very, very important. Thank you, Martha.
Thank you, Komlan. And so a person is asking, were there any standard indicators found between the countries at all?
Oh, yes, definitely. I think particularly the ones that, were being derived from the standard household surveys from PMA and DHS. So, measurement of modern contraceptive prevalence was, that indicator was consistently defined across, and the standard measures that you're looking at here, also knowledge and spousal communication, discontinuation, and intention.
Okay. With regards to donors, thoughts on how storytelling could be changed to better encourage more focused and increased or committed funding, especially when considering need for multi-year funding?
I mean, in terms of storytelling, one of the things that I've seen, I guess a couple of examples of things that I've seen where you can use SBC data to make the case is, first, a lot of times we hear that knowledge is already high. And so there's this emphasis on creating programs that try to address knowledge gaps. But when knowledge is already high, you need to think about other approaches that might be more geared towards shifting norms, or I have an example from some work in Niger where the knowledge was high, the attitudes were favorable, but when you got to a woman's perceived behavioral control, it really dropped off. It dropped in half of sort of the percentage that felt that they had the perceived behavioral control to adopt the behavior. And that's the kind of information that you can use to help sort of make the case that, okay, we've already addressed these, the sort of increasing information, and the person has a positive attitude towards it, but what are we doing to help empower them to adopt that behavior? And in this particular instance, they shifted the approach to it was related to hand washing, and they shifted the approach to focus on a male role in that behavior, and encouraging more communication between the partners to adopt the behavior, so that the woman had more support in the having a hand washing station. I think also I've seen instances where there's been enormous amounts of investment on the supply side, and that the behaviors don't really move. I've seen this with immunization coverage in Nigeria, where there's been huge investments on the supply side with cold chain and logistics and purchasing vaccines, but some of the attitudes towards vaccination are so entrenched, sort of related to rumors and practices postpartum, that all the investments in supply chain can only on the supply side can only sort of go so far, and you really need to be able to also sort of simultaneously address demand in order to improve adoption of the behavior.
I'll also just take this opportunity to mention that the Breakthrough Research Project has been working and continues to work on a portfolio of work, or a line of work, to make a case for SBC, so for SBC investment. And so what evidence to date do we have that SBC is effective, and differentiating by types of approaches, and then modeling that work to kind of demonstrate for advocacy purposes what is the bang for your buck if you invest on SBC, how far can that get you? And so I encourage you all to go to the Breakthrough Action and Research. We can put the link on the chat in a minute, to look at that, that body of work for family planning as well. A somewhat related question, Leanne, to what you were just describing. With regard to service providers, would you provide additional details on what improvements, if any, are needed to ensure better understanding of family planning resources and delivery of such?
What, for service providers, types of information needed? Mm-hmm. I think from a measurement perspective, there's an emphasis through our typical methods for looking at service delivery, whether it's sort of service readiness or quality of care type indicators that look at the technical competence of a provider, and they focus a lot on whether the provider is addressing all of the core competencies, or recommended counseling procedures that they've been trained on, and those are really important. But it also, we're seeing sort of these issues that are popping up related to biases, and some of the ones that are sort of talked about in the literature relate to providers that may feel biases towards unmarried adolescents, using methods, particularly long-acting methods, women who haven't yet had their first child and maybe sort of being less willing to encourage or engage in a conversation with women about adopting a method. And so we should really start to think about looking at those biases a little bit more closely, and thinking about what types of indicators we might be able to adopt to sort of see the extent that issue is prevalent in service delivery. And ultimately how much it influences contraceptive uptake.
Thank you, Leanne. Another question, have you considered expanding the ideational model to go beyond communications? This would help to capture SBC rather than only SBCC.
That's a great question. Yeah, I mean, I think it would be really interesting to sort of expand that out a bit more. That's a good idea. Because there are a lot more SBC approaches beyond just mass media and IPC.
Okay, what are the key standard outcome level indicators related to social norms and community practices for FP?
Sorry, what are the key
Standard outcome level indicators?
So we proposed one in the, as I can provide an example, and there's lots of ways to, there's one. So we proposed one in sort of these recommended 12 indicators, but there's a lot of different ways that this can go depending on, you know, what the community level norm is sort of been that you want to be looking at. This indicator that we have here, percentage of intended audience who believe that most people in their community approve of people like them using family planning, is kind of a general one. But you could look more specifically at, you know, percentage of intended audience that believe that most people in their community think that adolescents should not be using contraception, or some of those other types of attitudes related to family planning, about maybe long-acting methods or parity. I think one I sort of seen in the past in the Philippines related to norms around women who were becoming pregnant. We found that there was a strong community norm that people were not favorable to women having becoming pregnant later, and so that information was used to sort of help formulate a campaign that sort of looked at issues related to limiting.
Okay. Sorry, I just lost track of my questions. Okay. So I think since we have maybe time for a couple more questions, I'm just trying to see if there's a common theme here. So one of the questions that I think would be worth addressing is, I think one of the examples that you mentioned, Leanne, in the recommendations is countries that have successfully incorporated SBC indicators into national health information systems. Can you just talk about what an example looks like?
Well, I can provide an example. There was, although I don't have specifics on exactly how it was done, but I know that in Ghana, there was a concerted effort to really think systematically about developing standardized SBC measures that could be adopted in their routine monitoring system. And it was a successful approach. I believe it was led by FHI 360 and their Ghana program, where they worked closely with the government to sort of identify and put together recommended SBC measures that could be adopted through the routine monitoring system. That specific example I know is included in the indicator report that we're sharing and the recommendations, and so there's a reference for sort of more specific documentation on how that took place.
Okay, Mary Hadley is sending quite very helpful comments as well. One of her questions: would it be possible to cross-reference another behavior that did change over time? For example, HIV testing, use of mosquito nets. What triggered the positive or negative behavior change in those situations?
Yeah, that would be really interesting. Maybe that's something that we can do as we look more specifically with the RISE portfolio, because that's an integrated SBC program that's looking at maternal, newborn, and child health, and nutrition, water, sanitation, and family planning together. It's an integrated program. And so, yeah, it would be really interesting to look more closely and see how there's synergies or how we could learn from effective SBC approaches from other health areas.
Great. And again, from her, would you suggest different indicators for different vulnerable groups, adolescents, multiparous women, low educational levels, low socioeconomic status, urban, rural, etc.? And this might be a good moment to mention the indicator reference sheets. Then.
Yes. Actually, do you want to talk about the indicator reference sheets?
Yeah. So as a follow-up, I think to the material that Leanne presented today, we are developing indicator reference sheets to provide in more of a like how-to format for anybody who's interested, to guide you into how would you adopt these indicators, and how would you ensure that the definitions are kind of standardized enough to allow comparison, but then that you can also think through how they relate to your project or to your institution's work. And so this is something that will be coming soon, probably within the next month or so. We would be able to share that as well with all of you. Okay, so I think these other things that I'm seeing here are kind of more related to comments. If you are using percentage of women of reproductive age using family planning, will you adjust the results to take into account availability of inputs, so supplies, equipment, etc.?
I guess it depends at what level the measure is collected. If we're talking at a household level, that's difficult, but if we're able to triangulate that information at a facility level, that could be possible. Or adding in, sort of contextual information, triangulating data from multiple.
Yes, I think I'm not quite. Sorry. Just to add, I'm having a hard time thinking of a specific example in Francophone West Africa, but in many other places, especially large projects that are able to conduct facility level surveys with household surveys, and that are linking facility level data to their catchment areas, and are able to do this type of control for supply side factors, and then look at what's happening on the behavioral uptake side. So I think that's definitely a possibility, at least for the larger projects that are able to collect data on both of these fronts. So I think that we have covered most of the questions that have come through. Komlan, I just wanted to give you an opportunity to say any last thoughts before we close out.
Okay, thank you, Martha. I think that this is a good report, a good presentation, and I believe that it is important to have a follow-up on this presentation. In terms of questioning what we are doing now, I believe that monitoring and evaluation system need to be checked up again to see if we have a good measurement, we have a good indicator, and so on. So I advise my advice for each program is to put a question on the measurement system, and even throughout this work, we saw that there is a lot of programs they don't have like a monitoring and evaluation system in place. I think that it is important for a program to start by having a good system with the good indicator and so on. So my last thought will be that they can do better if they have a good system. Thank you.
Thank you, Komlan. Leanne, any last words?
Just thanking everyone for attending, and I haven't been able to see the comments come through, but I'm looking forward to learning from you and hearing about your experiences after we conclude.
Thank you all very much, and we will be sending out the presentation and the link to this recording.